start with we all
Ma'am,
know that
ma'am, I am first year resident MCH endocrine surgery at
no
SKIMS.
problem. You already would have known a little bit about MTC.
Thank you. Thank you.
So, hi, good evening, everyone. I know Saturday evening we're talking about MTC. That means all of us are so desperate to hear about it or discuss about it. So, MTC is a very, very interesting entity. I mean, it's interesting in many, many ways. So, the way it is associated, the way it actually is a continuum from hyperplasia to malignancy, and how it is associated with syndromes, and how it is a part of multiple endocrine neoplasia. And actually, it's a challenge to diagnose and treat MTC. So I remember whenever in HPJ we saw a young patient with a malignancy in the thyroid. So even though the FNSE says it is Bethesda 3, 4, follicular, whatever, still we would get calcitonin and CEA done sometimes because the way, I mean, we don't want to miss the baseline calcitonin CEA. Why? What is the reason? Can anyone tell me, like, why? What is the sensitivity of FNAC for MTC? Is it good, bad, better than PTC, worse than PTC? I think any of you can volunteer and come on.
Now it is less than PTC, less than differentiated thyroid cancer.
Yes.
It's
Somebody,
around 70%, 70 to 75%. Calcitonin is much more sensitive. More than 95% sensitive calcitonin rather than FNAC.
yes. Even though sometimes that we can see MTC on FNAC, they would have said follicular, microfollicular arrangement and everything. Even MTC can have that microfollicular kind of arrangement. So even MTC can have those. I will brush through all those things. I mean, it's not just for the exam, but I think once we go out, also we have to keep this in mind that MTC, we have to be, the surgery has to be the most important treatment. So anyways, so MTC accounts to less than 4% of all the malignant thyroid neoplasms, and about 14 to 15% of the deaths because of thyroid cancer. So it arises from parafollicular C cells. We all know that. It is a relatively aggressive type of it is a well-differentiated thyroid malignancy, but it's a relatively aggressive type. It's not a follicular one, it's a parafollicular one. So at presentation, half the patients are seen to have localized disease. Almost 35% have a locally advanced, and 13% have distant metastasis. So the stage and the age at diagnosis are the most important prognostic factors in case of MTC. And so early detection and diagnosis of the tumor are very, very important to attain cure. So this is the line that I'm stressing upon. The early detection and diagnosis is very important for cure, and we should not miss. Suppose we are operating on a thyroid malignancy in a young, it is okay to get calcitonin and CA, and though they are negative, it's okay to get them done, because if we know that it is MTC, we know that the surgery has to be really, really aggressive. So there are sporadic and familial forms of MTC. About 70-75% are sporadic, and familial is about 30%. And we all know that mutations in RET oncogene is a central for the development of MTC. And currently, miRNA epigenetic changes and other RAS, etc. genes are also under investigation. So more than 60% of patients with sporadic MTC have somatic RET mutations. So not only germline, even sporadic ones also have somatic mutations. And virtually all patients with hereditary MTC have germline RET mutation. It's not 100%, because sometimes it has been seen that the patient, they're having hereditary MTC, but they lack mutations in RET. Rarely it has been seen like that, but for all practical purposes, it is seen in these patients. And about 18 to 80% of the sporadic MTCs lacking somatic RET mutations have mutations in somatic mutations of H, KRAS, and rarely NRAS. But this is not the case with hereditary MTC. So it is mandatory to test for RET mutation in all the patients of MTC, because the percentage of having hereditary is quite high. So almost 30 to 35%.
Sorry to interrupt, ma'am. Regarding somatic mutations,
yeah,
Ma'am, is it essential to do somatic mutation testing in every
No,
sporadic
it is
MTC?
essential to do germline.
Germline, not somatic. What is the significance of somatic mutations?
So so actually, what is the significance? Is in most of the times. So I'll start with another question. What is the most common red mutation that we see in germline MTCs?
In germline MTCs, so ma'am, most common red mutation is
Codon.
634.
Yeah. So what is the
C64R.
most common codon mutation in somatic MTC?
But in somatic mutations, I think ma'am 918 is the most commonest.
Correct.
To be fine. Yes, ma'am.
Yeah. So why it is, I won't actually testing for somatic red mutation doesn't.
Ma'am,
Huh.
can it help in to gauge us the responsiveness to TKIs in somewhat?
Correct. Yeah. That's what we were discussing just now, right? So we have now red specific red tyrosine kinase inhibitors. And so if there is a mutation in this, they're going to act actually in some way or the other, the tyrosine kinase pathways. So whether it is RAS or RET, those pathways are mutated. So it is important to understand somatic as such may not really change the management as such, but
Yes, ma'am.
it also tells us to understand that M918T. Okay, one more question. So is hereditary MTC more aggressive or some sporadic?
Ma'am, sporadic is more aggressive than
What
hereditary.
is the reason you think?
Reason is, ma'am, hereditary is diagnosed earlier because of the screening.
What about what if we take only index cases into consideration?
Again,
Then
918 is most common, so 918
common
will be more
in
aggressive.
yeah, that is also one of the reasons.
Yes, when matched for stage, age, whatever, somatic MTCs are more aggressive. They have poorer prognosis compared to, say, a hereditary MTC because they lodge M918T mutation, which is an aggressive mutation, somatic, that is. Right. So, I mean, whether the gene is there in the germline or in the somatic, in the thyroid, in the parafollicular cells, it is the reason why it is forming the tumor in case of sporadic, right? So that's why it makes it more aggressive. That's one thing we all have to remember. So we tend to think that hereditary are more aggressive. It's not so.
Yes.
Yeah.
Thank you.
Yeah. So earlier we thought that the C cells were from what is that? Neuroectoderm, but right now we know that it is from endodermal in origin. So C cells are supposed to be located most numerous in the upper 2/3 of the gland, mostly in the posteromedial aspect of the thyroid lobes. So normal C cells can produce calcitonin and procalcitonin, and CEA comes only from the malignant C cells. That indicates it is dedifferentiated. So calcitonin, procalcitonin, and CEA are all important in the diagnosis and prognosis of MTC. So these are the parafollicular cells, interfollicular, whatever. These are between the follicles of thyroid. So there is a pathological continuum from C cell hyperplasia to MTC to lymph node involvement to systemic metastasis. So we still have a window of that means it goes this way, that we have a window of opportunity to treat when it is still at C cell hyperplasia in cases that are where it is possible, especially in syndromic cases. So what is the definition of C cell hyperplasia? More than or equal to 50 calcitonin immunostained C cells observed per 3 Lopa fields, that is into 100 magnification. So there is a neoplastic CCH and non-neoplastic CCH. In non-neoplastic CCH, the C cells are not having atypical features. It could be focal, diffuse, or nodular. And in neoplastic, there is a presence of clusters of C cells, at least mild atypia and with nuclear pleomorphism. So there are reasons apart from these MTCs that patient could have C cell hyperplasia, which we'll enumerate later. So like any other thyroid nodule, there is a workflow that we follow for MTC as well. So whenever there's patient with thyroid nodule, we do history examination, then do biochemical evaluation for the function. And to image, we use high resolution ultrasonography, Doppler, and give a thyroid score. And if available, elastographic can maybe clinch a suspicion. And then we do a guided fine needle aspiration and look at the Bethesda category. And in case of in case of MTC, we have additional aspects in the workflow. In biochemical evaluation, as we were just discussing, serum calcitonin, serum CE, and procalcitonin. And in FNAC, we can actually do washout for calcitonin also in case of suspicion. And genetic testing as for to differentiate whether it is sporadic or familial. And another additional thing is we have to look for other components of MEN2. So in case we have that indication in the particular patient, so we have to look for parathyroid disease and for adrenal pheochromocytomas. So coming to serum calcitonin and serum CEA, calcitonin is a 32 amino acid biomarker. It is its half-life is about 30 hours. So it is a post-translational processed product of procalcitonin. So the latest bioassays use a technique called as immunochemiluminescence. Which department in SGPJ does calcitonin estimations?
Endocrine surgery lab.
Endocrine surgery.
Yes. So we have calcitonin CEA estimations with us. So we keep doing these standardizations often. And so what is the technique that is used is immunochemiluminescence assay using sandwich technique with 2 antibodies. And the assay is to only assay the mature calcitonin concentration, but not the procalcitonin. So there could be wide variations among different commercial assays depending on the reagent and depending upon the way it is done. And so it has to be done from the same lab. The reference range is generally agreed to be less than 10 picogram per ml, which is normal. And it has been seen there are population as well as gender-based variations that even in about 10% of the normal subjects, the value could be higher than the typical range. But of course, we all going to interpret it in the context, right? So increased levels of circulating calcitonin unrelated to C-cell disease itself could be because of many reasons. Non-neoplastic reasons like renal failure, autoimmune thyroiditis, sepsis, pancreatitis, hyperparathyroidism, non-neoplastic hypogastremia, and some allergic conditions. And laboratory artifacts can also produce more spuriously high calcitonin levels, like the heterophile antibodies. And prolonged treatment with PPIs can also cause this. Other malignancies like small cell lung malignancy, large cell lung malignancy, breast cancer, neuroendocrine tumors, etc. Sometimes papillary thyroid microcarcinomas have also been associated with falsely elevated levels of calcitonin without a C-cell disease. So earlier we used to do something called as stimulated calcitonin testing. So it is not done these days. But if at all it has to be done, the practical pentacalcitonin is not available. The practical way of doing it is to use calcium gluconate, very quick, fast infusion. So we have to do it under continuous cardiac monitoring and measure the calcitonin at the baseline, then 2, 5, and 10 minutes after injection. And these are the cutoff values. So can I ask at this point of time, what is basal calcitonin? What is baseline calcitonin? Hello? Hello?
I'm just taking a guess here. Baseline is when we are working up the patient for the first time. So that would be our baseline calcitonin. But when we are going to do a stimulation test, we need a basal calcitonin against which we will measure the increase.
It's right in front of you, actually. Why
Yeah.
I say this is because I did my project in MTC and I used to always find it confusing too. Whenever I'm reading the literature, baseline, basal, baseline, basal. So for a while, I didn't know that these are different. Then one day, Professor Gaurav has educated me about baseline. That is when I actually could understand things. So the baseline is the one that is the baseline before stimulation. Baseline. Basal is the one to start with. Okay. So
Right, ma'am.
baseline
Thank you.
is the word. So
Sorry, ma'am, I didn't understand. The basal is
आपके सामने जो slide है अभी So
Yes,
if
ma'am.
we are talking about the calcitonin stimulation testing, right?
Yes,
So
ma'am.
in this particular calcitonin stimulation testing, the one that is at the baseline before stimulation is the baseline value. Basal
Okay.
value is the value that you start with whenever it's unrelated to stimulation testing.
Okay. Baseline is unrelated to stimulated,
when
and
you're
basal
reading,
is
when you're reading literature, these words are very, very confusing. So so I remember it like this. So yeah. So calcitonin, what are the uses? One thing is, of course, preoperative workup of suspected MTC or C-cell hyperplasia and screening for familial C-cell disease. And of course, genetic testing is a better one to diagnose whether the offspring is having or not in familial. And it's a preoperative prognostic marker because levels can roughly correlate with the extent of the disease and can guide the extent of surgery. And postoperative marker for cure and persistence or relapse, though not a very, very reliable one, but it is a good postoperative marker. And it's a prognostic marker in terms of doubling time. So 10-year survival is observed to be less than 6 months. The 10-year survival is about 8% only if the doubling time is less than 6 months, and if the doubling time is more than 2 years, then they are expected to live at least 10 years. So the calcitonin C measurement can also be done to assess the treatment response for whatever other treatments that we are doing. So like any other biochemical testing in endocrine diseases, there could be some pitfalls in. This is important that we all understand these pitfalls. These are actually similar for many assays. So we all have heard of the protein, the other protein assays also, right? Heterophile antibodies, hook effect, macrocalcitonin. So what is heterophile antibodies? It's so basically there are some antibodies which are interfering with our assays that we are using in the sandwich technique. So these can give falsely high or falsely low levels of our value. And hook effect is extremely elevated analyte concentrations. That means if the calcitonin is too high, like we often see it's more than 20,000, more than 30,000. So in such high extreme values, if we don't do the testing in dilutions, what happens is these molecules tend to aggregate together. They have the tendency to aggregate together, and then it can falsely give low calcitonin values. This is seen with prolactin also. This is seen with many protein assays, many protein analytes. So other thing is a macrocalcitonin. So every protein is a pre-protein. So the pre-protein high molecular aggregates or their excretion products, all in calcitonin, of course, it is the high molecular weight aggregates can actually give falsely elevated because we are only trying to assay the actual calcitonin. But if these are also assayed, then the value can be high. So calcitonin recovery test has to be done after precipitation of the serum with polyethylene glycol. These three things I think you can use for any protein assay. These are the pitfalls in estimation of any of these biochemical tests. In fact, PEG is the one that is used to do serum precipitation, and dilution is the thing for hook effect. So can anyone tell me other proteins that is important where hook effect can happen? Okay. So dilution is not performed very regularly. So the treating physician, and physician means you and I, surgeons, have to be very, very aware of these things. So if there's some incongruency between clinical findings and laboratory results, so we have to double check them by doing dilutions and retesting them. So CEA, once diagnosed with MTC, the ATA recommends to measure CEA because it indicates dedifferentiation. But CEA is not specific for MTC, and it's not used as a screening test for familial MTCs. And its elevation indicates slightly poorer prognosis, and therefore basal levels of serum CEA, that means before treatment. Basal is before treatment. Baseline is before collecting samples during calcium stimulation testing. So basal levels of serum CEA should be concurrently tested along with serum calcitonin for surveillance in the patient of MTC. So coming to ultrasonography, there are no specific things that point, like for example, there's microcalcification. We all think of PTC. There's no particular marker like that on ultrasound for MTC, but we know that it has the higher thyroid score, and it's a hypoechoic nodule, and there could be lymph nodes. All these things are there, but there is nothing specific that you can, which tells you that this could be MTC versus PTC in case of in ultrasound. But clinically, Professor Amit used to tell that the feel of the lymph nodes of MTC is rubbery. Personally, I mean, I never felt like that, but yeah, if asked in the exam, maybe you can say that thing. And coming to FNAC, it's the gold standard for suspecting for diagnosis of thyroid malignancy. Sensitivity is about 98% for follicular malignancies, whereas it's only 56 to 60% for MTC in a pooled meta-analysis. And the recent studies, because of maybe increased awareness and understanding of how the pitfalls, probably the sensitivity has grown up to 75 to 86%. So what are the classic features on cytology in case of MTC? Can anyone tell me what are the classic features of cytology in PTC? Come on. Is anyone there? Hi.
Ma'am, the nuclear features would be Ani nucleus with intranuclear pseudo-inclusions and nuclear grooving. Those are particularly characteristic for PTC. The cells would be arranged in papillae with fibrovascular core.
Okay.
Classic.
Yeah. So when it comes to MTC, what we usually see are the epithelioid plasmacytoid cells. They are cellular smears. Okay. So whereas in PTC, in PTC or follicular neoplasms, the cells could be scanty. So sorry, it could be cellular also, but the colloid is going to be scanty. Here they're going to be cellular smears with plasmacytoid cells, spindle-shaped cells, which are dispersed to loosely cohesive patterns. So the nuclear eccentrically placed, and the chromatin is coarse granular, and the cytoplasmic granules are azurophilic, and background could have amyloid in about 35%. And this giant, the multinucleated and binucleated cells are a minor criteria to diagnose MTC, actually. So in my study, I used to read the pathology reports, and whatever is mentioned here, like the epithelial plasmacytoid cells, loosely cohesive patterns, coarse granular chromatin, azurophilic granules, these are, and binucleated and multinucleated cells. These are very, very characteristic of many of the MTCs. It's very interesting. I think you, when you go back and read, you will probably appreciate it more. And if classical features are seen, of course, MTC is very straightforward, but recommended, of course, to be still confirmed with the documentation of serum calcitonin, and because there could be broad differential diagnosis. And we know that what are the implications of diagnosing MTC beforehand, because the extent of surgery and all. So it's important that we have the confirmation. So even MTC has variants. So there could be spindle cell variant, follicular variant, papillary variant of MTC, giant cell variant, clear cell variant, oncocytic variant, squamous variant, but these paraganglioma-like variant. Actually, in my study in sporadic MTCs, I've seen some patients who have paraganglioma-like MTC. In our OT histopathology data, we have 2 patients with paraganglioma-like MTC, and we have mixed PTC MTC. We have at least 6 or 7. I'm very sure. And other one that we have seen is oncocytic variant of medullary thyroid carcinoma in SGPJ data. I'm sure other centers also have such data. So, and fortunately for us, as such, the MTC is rare, and the variants of MTC are even rare. And on FNAC, MTC.
Ma'am, are there any aggressive variants like in PTC? मतलब they're aggressive. Are some variants these are aggressive?
नहीं, ऐसा कोई स्टडी मेरे ख्याल से नहीं हुआ है.
Okay.
Yeah, such it is so rare, and usme I'm saying that out of some 300 patients, 2 had paraganglioma-like, and maybe 3 or 4 had oncocytic. PTC
And
with
there is something like a classic PTC जैसे होता है, वैसे classic MTC is also there.
I don't think so. I don't. Classic तो होना होगा. इसीलिए there are these variants. So,
Okay.
but I mean, they're not very relevant in treatment, I think.
Treatment outcome. But aggressiveness में ऐसा नहीं है. There are more aggressive, some are less aggressive.
To my knowledge, I think ऐसा कुछ नहीं है. Maybe we can
Okay.
read it up.
Okay, ma'am. Okay.
Update me if you find something.
Thank you.
Fortunately, these are uncommon, they are saying. So, MTC is a great mimicker on FNAC. Micro MTC doesn't lack classical features like we just talked about. And MTC can mimic a follicular neoplasm because the cells could be epithelioid, and they could be small blue round cells which are arranged in follicular clusters resembling a follicular neoplasm. And in one particular study, microfollicular pattern was seen in about 13 out of 38 cases. Conversely, apparently in some follicular neoplasms, cell dissociation is also possible, and the presence of maybe polymorphic cells can also occur resembling MTC. So vice versa. So FNAC, what I'm trying to say is FNAC is not a great thing to rely on to completely diagnose MTC. So Hurthle cell neoplasms often present as hypercellular discohesive single cells. So we all know how the pattern of cell arrangement in PTC and all, right? Follicular, this microfollicular or their papillary patterns, and the cells are all adhered together. Whereas in these neoplasms, they're discohesive, they're separated, they're not together. So even Hurthle cell neoplasms can have hypercellular discohesive cells and granular cytoplasm. So we have to then do calcitonin C8 and these tests to understand whether it is MTC or not. So amyloid is seen only in about 34 to 80% of the MTCs on cytology and may mimic colloid. But amyloid doesn't show any typical cracking after drying up like the colloid. So Congo red stain is the useful one to confirm presence of amyloid. But amyloid presence is not seen only in MTC, because the systemic amyloidosis can have thyroid amyloidosis, and I was fortunate to operate on a patient who has only thyroid amyloidosis. And when I was operating, the thyroid was like, it was just breaking. It was powdery and it was just breaking up into pieces. It's very difficult. I was wondering that patient had hyperthyroidism. It was, I had diagnosed it as toxic MNG, and I took up for total thyroid. It's a big goiter. And when we were operating, it was very much, it's powdery actually. The thyroid is powdery and it just keeps on melting in our hands. So that is also a possibility. And some of bodies can also be seen in MTC. So I think we can skip this. And washout for calcitonin in FNA samples is also useful, especially in lymph node. One of my colleagues, contemporaries, Dr. Nitish, had a washout study from lymph nodes for thyroglobulin. So similarly, we can do calcitonin washout from lymph nodes to see if there are any metastases instead of frozen section, of course. So genetic testing from FNA, like other thyroid malignancies like FMR, then Thyroseq and Thygen and all these. So cost effectiveness is questionable. If we might as well do calcitonin and CEA. And additional imaging may be required to know the extent of disease, especially CECT neck and thorax. And bone scintigraphy is better to diagnose bone metastasis. And Dotanoc scan, Dotatate, Dotatalk, and Dotanoc. All these are useful in looking at because actually these can have this can show adrenal mass also, and these are not a must. Actually, a well-performed CECT neck and thorax with bone scan gives a very, very good picture than a PET scan. FDG is not routinely recommended unless we have suspected like really dedifferentiation and that we're not able to see some lesions. And CECT is going to show all those lesions anyways. So of course the whole body will be covered with with the PET scans, but it's not routinely indicated. But we anyways do it if we are suspecting.
Ma'am, CCT and bone scan versus PET, CCT and bone scan is better than PET as initial workup. rule out metastasis.
Because CECT is anatomical and if this rotamine is functional. So it is dependent on somatostatin receptors. What if the tumor is not expressing those receptors, right?
Yes, yes.
So even in case of paragangliomas, to look for multiple paragangliomatosis, the most sensitive is a CECT compared to PET, right? The similar
Yes.
thing goes here also. And so
Okay.
retroncogene testing, germline, the DRET gene is located on chromosome 10, Q11.2, and it encodes a single pass transmembrane. This could be a question actually, RET gene, RET protoncogene, then you have to write all these things. So it may look like it is very, very dry, but it's important. It encodes a single pass transmembrane receptor of the tyrosine kinase family, and the mutation is a gain of function mutation. So germline RET is seen in inherited MTC, MEN2, and somatic in thyroid C cells, which results in sporadic MTC. And MEN2 is an autosomal dominant syndrome with very, very high penetrance. And the prevalence is about 1 in 30,000 in general population. And hereditary MTC is typically bilateral and multicentric because they all have the predisposed mutations. And prognosis of inherited MTC is better than sporadic for a given stage of the disease, of course, except MEN2B, right? So clinical presentation and manifestations of MEN2 associated MTC are similar to those of sporadic MTC. So the clinical presentation is, of course, going to depend upon the size, the location, and everything. But prognosis is better in inherited. The classification of MEN2 type 2A and type 2B. So type 2A, so classically has MTC, FIO, and PHPT. And there is M2A with cutaneous lichen amyloidosis, MEN2A with Hirschsprung's disease, and familial MTC without FIO and parathyroid disease. MEN2B, MTC, FIO, and other features like mucosal neuromas, intestinal ganglioneuromas, Marfanoid habitus. So have you all seen any MEN2B?
Yes, ma'am. There was one case when SGPGI.
What's the name of the patient?
Reena.
Okay, Reena.
We
She
had
had a very
joined
aggressive.
and in the ward. So that was the first meant to be that way. The first and the only actually. Till
Which year did she come in?
2020.
2020?
December. We joined in December and she was in the ward.
Oh, okay. I saw 2 patients of MEN2B. So when we were there, and of course we know the older ones.
Ma'am,
Anyways,
although sporadic MTCs are more aggressive than hereditary, but hereditary has got better prognosis.
sorry.
The hereditary has got better prognosis than the sporadic,
Yeah.
except
What was the
meant to
first
be.
sentence? Yes, except meant to be.
Except
Yes.
meant to be.
Yeah, meant to be as it's so rare. So M9180 is not very favorable. It is aggressive. Whereas the classical MEN inherited MTC, MEN2A is better prognosis than sporadic. So
Might be it can be attributed to the screening also, and as such case to case basis also they've got the better prognosis than sporadic.
no, it's not because of screening. I'm saying that if you match stage and age also,
Then also inherited
is better because the mutation itself, unlike MEN2B,
918.
the other mutations are not so aggressive.
Yes.
So, ma'am, is there any difference in inherited medullary thyroid cancer and familial medullary thyroid cancer? Are these two different things or this is same?
No, they're same.
Huh?
They're same.
Okay, ma'am. Because I have seen many
What is inherited, what is familial? Yeah, I mean,
is it same?
the usage is they are not same in the sense the usage I'm using here in the context is the same. If you really go into details, I mean, to talk genetics, inherited is different from familial. So there could be familial diseases which are not inherited also, right? So all familial diseases need not be inherited, but in case of MEN, I'm just using them interchangeably here.
Okay, ma'am. So, ma'am, that means Okay, ma'am. All right.
In general parlance, inherited and familial are not same because all familial diseases need not be inherited. But
So, ma'am,
here
here
I'm
what
using them interchangeably.
Okay, ma'am. So, ma'am, what we here are saying that inherited medullary thyroid cancer has a better prognosis. It
Yes.
does not apply to familiar medullary thyroid. That may have
No, it does. They are same. They are same. Here they are same.
Okay. Okay.
My
ma'am.
bad,
All
actually.
right.
I should have just stuck to one. I should have just stuck to inherited. But they are used like that interchangeably. If today were a class of medical genetics, and if I say they are same, I would be wrong.
All right, ma'am. All right.
Yeah, yeah.
Okay.
So structure and function of normal RET and its product. So RET protein is a receptor tyrosine kinase. I'm just reading out because I think these sentences you can remember and write in the exam. This is actually a question. So it's a receptor attached to tyrosine kinase enzyme, and it transduces growth and differentiation signals in several developing tissues, including those derived from neural crest. And it is expressed in C cells of thyroid gland, adrenal medulla, neurons, and other tissues. So it has 4 natural ligands: glial cell derived neurotropic factor, neurocurin, artemin, and persephine. Yes. So interaction with these molecules results in dimerization of the RET, cross autophosphorylation, and subsequent phosphorylation of the intracellular substrate, which is true for any dimerizing receptor tyrosine kinase. So that means whenever these natural ligands come to the surface, the extracellular domain, the receptor molecules dimerize, and then the subsequent cascade begins. So the extracellular part with a ligand binding domain, so has a acadherin-like domain and a cysteine-rich domain. Okay, you can remember this. There is a acadherin calcium-dependent cell adhesion-like domain and a cysteine-rich domain. So there is extracellular part, there is transmembrane part, there is intracellular part, and the extracellular part has a acadherin binding domain and a cysteine-rich domain. So most of the mutations occur in this cysteine-rich domain. And there is a single domain in the transmembrane part. Domain means area. Intracellular part with 2 tyrosine kinase subdomains. That is tyrosine kinase 1 and tyrosine kinase 2. So the co-receptor is GFR alpha. So whenever there is a ligand and co-receptor engagement, then there is going to be dimerization like this, and the cascade begins. So appropriate growth signal to the nucleus is given. Okay, is this clear?
Yeah.
Yes, ma'am.
So cysteine-rich regions are extracellular, and majority of the MEN2A mutations occur in one of the 5 cysteine residues. That is 634, 634 exon 11, exon 10. See, most common is exon 11, 634. Others are exon 10, 605, 11, 618, and 620. If you really go through the data, these are the most common ones. These are all in the extracellular cysteine-rich domain. And ligand-independent dimerization of the RET receptor and constitutive activation. So if there is a mutation, there's no need for ligand for these receptors to dimerize. They spontaneously dimerize because there's a gain of function mutation. And these mutations in these exons 10 and 11 in these particular things cause auto dimerization of RET receptor and constitutive activation. A mutation in codon 634 in exon 11 is associated also with hyperparathyroidism and FIO in MEN2A and is the most common genetic defect in this disorder. So there are intracellular tyrosine kinase domains also. This leads to continuous RET activation but no dimerization. That means there are single receptors but still they are activating their downstream tyrosine kinases. What are those codons? Those codons are exon 13, 14, 15 ka 768, 804 and 891. And 891 exon 15, we have all these mutations in our data. If anyone is interested, they all can go through it. So we have 13 exon 14, 15 and 891 is seen in familiar MTC without parathyroidism, hyperparathyroidism, and VU. It is seen in TK1 domain. So, but they are only minority in terms of incidence. Codon 804 mutations have been identified as gatekeeper and can result in reduced sensitivity to some RET targeting multikinase inhibitors. So, Dr. Yuvraj, this is one more thing probably which we all can understand. If there is a somatic mutation in 804, still it could, I mean, this is of course about hereditary, but
Yes, ma'am.
still result in this one. So,
Understood.
yeah, these are all tyrosine kinase 1. Okay, intracellular domain tyrosine kinase 1.
Yes, ma'am.
Intracellular domain tyrosine kinase 2. MEN2B associated tumors. 2B, that means they're aggressive, caused by mutations in intracellular TK2 domain. A single exon 16 M918T methionine to tyrosine, I think. More than 95% of the cases of MEN2B have this. So, because it's such a lethal disease, we hardly see that these patients survive, procreate, and then the baby gets MEN2B. Most of the times, it's a de novo mutation that has happened. But another mutation, A883F in exon 15, it's a rare one, has also been found to be seen in MEN2B kindreds. And there is something called as atypical MEN2B, because of dual tandem mutations. Matlab, line to line, two RET mutations can happen, and that can result in more aggressive form that can have features of MEN2B, but in an atypical way. This is so rare actually. So this can also happen. So that's not tyrosine, threonine, methionine to threonine. Okay, this is how we're going to represent it. So cysteine-rich domain and TK1 domain are MEN2A, and TK2 domain is predominantly MEN2B. So somatic mutations seen in about 60% of sporadic MTCs, and most are of codon 918, exon 16, and in mutually exclusive fashion, as if RET is positive mutation, RAS can't be. I mean, RAS and RET have not been seen to be together mutated in case of sporadic MTCs. And these mutations, of course, are present only in present tumor cells and not genetically transmitted. So if someone asks you to classify MTC, hereditary and sporadic, and sporadic can have RET or no RET, and they could have RAS also, of course. And the presence of somatic RET mutations correlates, Dr. Yuvraj again, the presence of somatic RET correlates with lymph node metastasis, persistent disease, lower survival, especially when seen in exon 15, 16 of RET, and they have worse prognosis while those. Yes, so it can prognosticate, it can it can guide us in counseling the patient. So even in sporadic MTC, RET analysis has this kind of importance. So we all have heard of genotype-phenotype correlation. So we have risk categories which can indicate the age of onset at MTC and the potential to develop local and distant MTC metastasis. And the surgical outcomes and survival depend on the stage and pathological features in all genotypes. So if you actually look at, if you group together MTCs of a particular, sporadic ones of a particular stage, and then the prognosis is going to depend only upon the stage, but not the risk category. So the risk category is only to indicate at what age the disease is going to start. So early diagnosis by screening of at-risk family members in MEN2 kindreds is essential, because MTC is we know that it's life-threatening disease. I think I messed up what I just said. So basically, the prognosis is going to depend upon the stage. The risk category is only to say whether at what age we may have to start looking for the features of MTC or C-cell hyperplasia. So coming to till now in literature, this is from actually up to date. So the youngest seen to have MTC, but not facial hyperplasia, is 9 months with 918 mutations. And so the prophylactic surgery is recommended in highest risk, which is 918. Acha, so before I go there, there is highest risk, high risk, and moderate risk, right? So in genetic, in genotypic classification. So 918 is highest, and high is 634 and 883, and moderate is rest of the all others. So annual screening can be started from 3 years in case of high risk, and 5 years in case of moderate risk, and prophylactic thyroidectomy within first year of life for highest, before 5 years for high risk, and childhood or young adulthood bar SOS in case of moderate risk kindred. So this risk is what is clearly only to indicate this. The grouping is only to indicate at what age we should start screening and to perform prophylactic thyroidectomy, not to say that they have any other implications as such. It's all going to depend upon the stage. So once a germline mutation is identified in index patient, RT analysis should be performed in the first and second degree family members. And genetic counseling is for RAT should be offered to the following groups: all MTC patients and first degree relatives of a patient with a proven germline mutation, parents whose infants or young children have the clinical characteristics of MEN type 2B. So patients, like, what are the features that we can see in children, in infants with MEN 2B?
B would have mucosal neuromas, ganglioneuromatosis, marfanoid habitus. 2B.
I mean, in infants. Yeah, mucosal neuromas could be there.
Mainly.
Yeah, in Robbins, there's a diagram also of this baby having this one. And all children with infants with Hirschsprung's disease have to be evaluated for RAT mutation. So they may have future development of, if they have germline, then they can have MTC later. So patients with CLA, patients with Hirschsprung disease should also be tested for RAT. So affected families. Yeah. Yes, please. Sarah?
No, ma'am. I was just asking. Hirschsprung is meant to be. That's all.
Actually, it's about the mutation of RET in Hirschsprung's disease apparently is 40%.
Yes.
So, like we recently had a presentation of infant GI malformations. Then in that they were discussing. So there's about 40% of incidence of mutations of RET in Hirschsprung's disease, infants with Hirschsprung's disease. So we have to test all these kids for that. So affected family members who also require screening for MEN2 associated tumors. It provides clinical benefit that should accrue from earlier surgery, as MTC is life-threatening. And it definitely establishes that an individual doesn't carry the MEN2 mutation and eliminates for the need for unnecessary fears and unnecessary testing. So, and avoids unnecessary thyroidectomy for genetically normal subjects. Because we can't just depend upon pentagastrin tests or calcium stimulation tests. We can depend upon genetic testing. So prophylactic thyroidectomy, if there is no calcitonin elevation, only total thyroidectomy. If there are any nodules, or if there is any slightest elevation of calcitonin, then we can choose to perform TT plus prophylactic CCLND. But in children, we generally try to avoid it because they're too young and we can't afford to lose the parathyroids. And so all the patients should be referred to a experienced endocrine surgeon who can perform these surgeries and who are trained to do it in pediatric population. So I haven't yet got a chance to operate on a pediatric thyroid. Hopefully I get soon. So coming to FEO in MEN2, 40% of the patients with MEN2 can have FEO and 50% in MEN2B. And there's a large variability in penetrance. There are intrafamilial and interfamilial variations. So for the same mutation, if each person can have a different presentation. So intrafamilial and interfamilial variations are very, very common. And again, like the C-cell hyperplasia, there is adrenal medullary hyperplasia and increased likelihood for bilateral FEOs. And extra adrenal FEOs are also can happen, but it is very, very rare. Malignancy has not been reported, and estimation of metanephrines and imaging, of course. And PHPT is seen in about 30%. So the highest penetrance is for MTC, next comes the FEO, next comes the PHPT. And it's often, can I ask a question? I'll involve others also. Dr. Rijita? Acha,
Yes,
Dr. Pratyusha, you are not talking anything. Dr. Rijita, can you please tell me which familial hyperparathyroidism has bigger parathyroid hyperplasia and more aggressive, higher levels of calcium? Is it MEN1 or MEN2?
In MEN1.
Correct. You're right. So MEN1, they tend to have bigger hypoplastic nodules and they have higher calcium. So we are going to do calcium and IPTH in these patients. So coming to reproductive options. So of course, it's a very, very complex discussion with the patients because they have to be counseled about the possibility of their children having mutation, and then prenatal testing and pre-implantation genetic testing if it is IVF, all these. And I as a part of IVF, pre-implantation genetic diagnosis is a protocol, and so they can of course choose whether they want to continue with it or not. And coming to variants of MEN2, classical is FEO, MTC, FEO, and PHPT. Codon 634 most common. There could be CLA. So CLA is typically seen on it's a pruritic, scaly, papillar, pigmented rash in the interscapular region or on the neck, lower part of the neck. So it's because of amyloid deposition, and it is predominantly seen with 634. So MEN with Hirschsprungs, it's a motor disorder of the gut caused by failure of the migration of neural crest cells. And there is a narrow, one question, anyone can answer this. Which is the constricted part which is the disease part in case of Hirschsprung disease, the normal one or the constricted one or the dilated one? Dr. Pratyusha?
Hi, ma'am. Good evening.
Hi.
Constricted part is aganglionic.
Yes, you're right. So constricted part is unable to dilate, and so there is accumulation of the feces, and so the proximal part dilates. The normal part is the one that is dilated, and the constricted part is the one that is abnormal. Okay. So RET malfunction accounts for about 50% of ML and 20% of sporadic cases of Hirschsprung disease, it seems. So at least eight genetic mutations have been identified. So aganglionic portion of the Hirschsprungs fails to relax, causing a functional obstruction. So we all know suction rectal biopsy to look for hypertrophic nerve endings is the diagnostic thing. And the prevalence, this is again for us. What is the prevalence of Hirschsprung disease in MEN2? It is 7.5%. So if a child is having Hirschsprung disease and then the family history of thyroid disease in the family, it could possibly be MEN2. So Hirschsprung disease may be the first presentation of MEN2A. MTC FEO parathyroidplasia with similar frequency as those with classical MEN2A. So coming to familial, strong predisposition for MTC, but not others. And the clinical designation of FMTC has been changed to MEN2A after diagnosis of FEO and hyperparathyroidism in a family member over time. This happens with familial isolated hyperparathyroidism also, no? FIHPT. So we had a family who had 2 generations of FIHPT, and suddenly one boy developed Cushing syndrome. So then patients had pituitary. So it was then changed to MEN1. Do you know this family? Any of you?
No, ma'am.
There's one family who comes to follow up. They have been labeled as FIHPT, that is familial isolated hyperparathyroidism, And one of the current generation, the third generation boy, developed pituitary lesion. So now it has been relabeled as MEN1. Similarly, it can be FMTC versus MEN2A. And type 2B we just have been seeing. So MTC PFO are like MEN2A, but there's no parathyroid disease. There are mucosal neuromas, typically involving the lips, tongue, and intestinal ganglionomas, and disturbance of colonic function are common, including chronic constipation and megacolon, irrespective of whether not being Hirschsprung's. So a marfanoid habitus, myelinated corneal nerves, and MTC is the most common component of MEN2B. It's often more aggressive, starts earlier compared to MEN2A, and the treatment of MTC depends upon the stage of the disease. Primary treatment is extensive and meticulous surgery and only surgery. Surgical resection, and cells do not concentrate radioactive iodine, so no TSH suppression, and there's no radioactive iodine therapy. So there is very limited role of external beam radiotherapy, and we don't have any good chemotherapeutic agents as of now. Of course, now we have RAT specific DKIs, but still surgery is the most important. So doubling times of calcitonin and C are very important prognostic, and surgery always has to be a one step ahead, like one echelon higher. And I mean, if it is involving thyroid, do sentinel compartment dissection. If it is involving sentinel nodes, do lateral neck dissection, something like that. So lymph node management is based upon the clinical imaging biochemical picture, and there are various methods that each one follows. And the indications of prophylactic lateral neck dissection have been debated. So but still, I think it is better to do over treatment in MTC than in PTC. We wouldn't say that. In MTC, it's important. So, you know, the great Mackens and Raleigh, Andrea Mackens and Raleigh from Germany. So they have so much data on MTC. So they have done a biomarker-based risk stratification for previously untreated MTC. So, and they have recommended treatment based on this. So ipsilateral neck involvement is a possibility if it is more than 20 picogram per ml calcitonin, and contralateral central neck if it is more than 50, contralateral lateral neck if it is more than 200, and upper mediastinum if it is more than 500. So the treatment can be guided with this particular understanding. In their observation, based on these calcitonin values, these are the levels that are involved. So that's how we have to decide. Ipsilateral, central, and lateral neck if it is more than 20. That's what they follow. So contralateral central neck and then contralateral lateral neck. Of course, upper mediastinum, we may have to rarely open a little bit of the upper sternum. So at least 50% of the patients achieved biochemical cure when basal calcitonin was below 1000. None have showed cure if the basal was higher than 10,000. मतलब ये तो systemic metastasis हो गया ना, more than 10,000. So of course now with our experience we know that levels more than 200 may need bilateral compartment oriented neck surgery to reduce. Acha, this particular thing is called as compartment oriented neck surgery. This is done to reduce the number of reoperations. So what are sonographic predictors of lymph node mets? Sonographic features of patients with MTC. Acha, tumor size more than 1.5 centimeters, and the margins are irregular, and the location is subcapsular, and if there was extrathyroid extension, it's very logical. These things, these patients are likely to have lymph node mets, occult lymph node mets, so better to do lymph node dissection. And calcitonin more than 60. This is another way to decide what kind of surgery has to be done. So if calcitonin is more than 65, then also you try to do lateral neck dissection. There is a great deal of interest in doing SLNB in MTC, but it's not been standardized yet. And our good friend Nada Santrak, she's done it with methylene blue, and using methylene blue, and few have done it with radiolabeled dye, but it's still not into the guideline stage. So what is surgical management of locally advanced metastatic MTC? So advanced disease, the goals are more palliative and to get, so it has to be very logically planned, and you should understand why you're doing it. And if the MTC is invading trachea, thyroid cartilage, or esophagus, the extraoperative surgery is determined based on the ability to maintain the normal functioning, right? We don't want to leave the patient with unnecessary problems. And these are best to be decided on an individual basis. So coming to follow up on outcomes. So how do we follow them up? After we perform the surgery, evaluation is done first for 3 months and then 6 monthly. So if calcitonin is, if at these times, if the calcitonin is normal, then physical exam and ultrasound, that is enough. And if they are less than 150, then we may have to evaluate them further. If it is more than 150, we may have to do these PET scan and CECT to determine if there is any. I mean, here I think the role of Rotenok comes because which area to perform CECT is better determined by whole body imaging. So I think this is where Rotenok, the PET scans are more useful. So what is biochemical cure? It is post-operative normalization of serum calcitonin, and it predicts a 10-year survival rate of about 98%. So about 3% of the MTC patients with initial biochemical cure remission can develop recurrence later, about between 1 to 7.5 years after surgery. So long-term biochemical cure is defined as undetectable basal serum calcitonin at last biochemical follow-up in patients who had received no other treatment beyond initial surgery. So 30-40% patients can have overall biochemical cure, and node negative, it is of course going to be higher, and in node positive, it's going to be slightly less. So what are the factors where biochemical cure is unlikely? If there are more than 4 lymph nodes involved, and if the calcitonin is more than 500. And at the French Institute Gustavus, they have seen that selective venous catheterization with calcitonin measurements to localize occult metastatic disease in MTC patients whose postoperative calcitonin were below 500, apparently. They have tried this to localize the metastasis to guide treatment. So survival, the 10-year survival rate is in unselected patients in MTC is about 75%. But it is to less than 40% in cases of locally advanced or metastatic disease. So I don't know if anyone is hearing, they're all online, they're all slept off, I don't know that. Dr. Swarna? Hi, Dr. Swarna.
Yes, ma'am. Hi, ma'am.
You're from?
I'm from CMC.
Wow, okay. So who else is there along with you in CMC? You're the only one?
Me and Meghna.
Meghna, Dr. Meghna. Okay.
Yeah. Yes.
So yes, metastatic MTC, like any other metastatic disease, it's to palliate the symptoms, and if there is hormonal excess, treat that. If there is palliative, I mean, if there's a, of course, this is same for any malignancy. The thing is, there could be associated diarrhea because of the calcitonin itself, and there could be Cushing's syndrome sort of a thing. And yeah, the intention, the treatment depends upon what kind of meds are there. And so how to manage patients with possible distant meds? If the calcitonin and CA are high, but there's no radiological meds, then we obviously are not going to treat the reports. And if there is elevated serum calcitonin with necessitating extensive reoperations, then if distant metastases are there on imaging, then they're not candidates for locoregional surgery with curative intent. So additional evaluation for METs, open or laparoscopic evaluation for liver and selective, and these are all, I think, I mean, these are all individual patient based. We all, I think, know the logics behind all this. So palliative therapy can be used as and whenever it's needed. And if there is hypersecretory sort of a diarrhea, we can use somatostatin analogs, anti-motility drugs, and Cushing's, the ketoconazole and all can help. So liver mets can occur in about 40-45%, and large mets may need resection because they may burst or cause severe symptoms of the patient. And chemoembolization followed by resection is also a possibility. And there are other options like radiofrequency ablation and Now, bone, of course, if they're in the weight-bearing area and they're likely to cause a pathological fracture, we're going to treat them. And bone bisphosphonates are going to give strength to any lytic metastasis, and they're going to help the patient. And brain mets, of course, we have SRS. It's similar in any malignancy, I think. So coming to systemic therapy in distant mets. So depends on the rate of tumor progression, quality of life, what is the current versus expected, and what is the performance status of the patient. And there is limited efficacy of all the therapies, and there are potential toxicities. So, Dr. Sarah, what are the various systemic therapy options that we have?
Ma'am, they would be in the form of TKIs,
Yes.
which are most commonly cabozantinib and vandatinib.
Yes.
For each metastatic site, locoregional therapy can be given. And as a
Systemic
second,
therapy.
sorry, ma'am.
Systemic therapy, not palliative therapy. Systemic therapy.
Okay.
Yeah.
Okay, sorry, systemic therapy. And in cases of chemotherapy has been tried, but the response is not adequate, so they are very rarely given. As second line, lutetium therapy is given.
Yeah, lutetium therapy is a PRRT, peptide receptor radionuclide therapy. TKIs,
And the
PRRT.
somatostatin, sorry, ma'am. Somatostatin receptor antagonists also can be used as a systemic inhibitors.
They are actually, I think they palliate the symptoms, but not, I think they're not like systemic therapy.
Okay. SSTI.
See, basically, lutetium is the one that is the active element, and it is tagged to octatate. It's a somatostatin receptor analog, right? So,
Yes, ma'am.
I mean,
Because this can be used in somatostatin receptor inhibitors can also be used in targeting these receptors 2A and 5, which are there in MTC.
yeah, but they're not but they're not cytotoxic.
Yeah, but can be used as a palliative or
It can be used. So we're talking about
Mhm.
systemic therapy. Systemic therapy
Okay.
is active molecule that is going to either make the cell static or kill them. So there should be an active element, right? The active element tagged to octatate is lutetium-177. Okay, you get my point, right? Yes, we have just said that we can use somatostatin. Somatostatin analogs can be used. So if you tag those somatostatin analogs with lutetium, then that's actually going to act like a systemic therapy, a tumoricidal. Like radioactive therapy, we are using lutetium therapy. So thankfully, MTCs have a simpler mutational burden. It's just the RET receptor and the targeted therapy with small molecule inhibitors targeting the mutant driver kinases. There's a lot of work going on this. So we all know that there is a RET activation, and these are going to inhibit these tyrosine AKT, phosphatidylinositol 3 kinase, and MAP kinase signaling pathways. And so what are the options? As just now Dr. Sarah has enumerated, vandatinib, cabozantinib, sorafenib, and sunitinib are the options. And Pratyusha, Dr. Pratyusha, or hi. So you're aware of these trials, right? Zeta trial, exam trial, and so these are the various trials that have tried using vandatinib, cabozantinib, and maybe how many ever times we read, we just have to remember that mainly for MTC it is vandatinib and cabozantinib, and of course sorafenib is a non-specific one that can be used in this as well as in other thyroid malignancies. And the dosages and the PFS, prolonged progression-free survival, all these have to be remembered, all the numbers. And so there are mutation selected. These are non-specific. Coming to mutation specific selective kinase inhibitors, We have selpercatinib and pralsetinib. And actually, you have to tell me what is the latest about selpercatinib. Is anyone what's the Dr. Rijuta? I'm sure you have something more to tell me about selpercatinib.
Don't know, ma'am.
Because I didn't read about it latest. So here it says there was a, I think it's finished now, this trial. So is anyone aware? Have you all read? Please go and read. So the current research focus is only on the genetics, epigenetics, and targeted therapy. And there is a there was an article shared by Dr. Sabasar about micro MTCs. So what is the discussion going on about micro MTCs? Can anyone tell me?